The East African tradition of the Maasai tribe is to greet one another with the words Kasirian Ngera, which is Swahili for, so how are the children? In that community, the well-being of their children is the highest priority. If you are interested in participating in thought-provoking conversations about the well-being of children and families, please tune in every Wednesday at 3 p.m. to Fresh Start Today on 860 AM WNOV. Together, we can save our children. Good afternoon. You're listening to Fresh Start Today. I am your host, Jermaine Reed, along with Sean Roby, and our engineer is Mr. Keon Malone. How you doing there, Keon?
Things all right.
How are you doing there, Sean Roby?
Hello, hello.
Hey, we have a great show lined up for today. We got a couple community announcements that we're going to make, but we're going to be talking about, the topic is unborn child abuse, Wisconsin's cocaine mom law controversy, and we're going to be talking about prenatal drug exposure, the impact, if any, on children who are developing in utero. So it's going to be a very interesting conversation, and you can join this conversation by calling 414-444-5250, 414-444-5250. We have some special guests in the studio with us this afternoon. We have Shauna. Shauna knows firsthand the impact or the effects of this, what they call the Act 292, I believe it is, in Wisconsin. It went into effect in 1997. I've read some accounts in 1998, so I'm not really sure. But these fetal protection laws. And so we'll be hearing from her and her experience with this law. And then we also have in the studio with her is Dr. Harkey. Kathy Harkey is a board-certified obstetrician, gynecologist. She is currently affiliated with the Fetal Hospital of Fetal Hospital Wisconsin, the Medical College of Wisconsin. She is also the chair of the Wisconsin chapter of ACOG, and that is the
American Congress of Obstetricians and Gynecologists.
I have so much to learn today. And just last week, she was honored with the 2015 ACOG Improvement in State Legislative Advocacy Award for her work in spearheading legislative advocacy among physician and women's health groups in Wisconsin. Wow. And all the way from Baltimore, Maryland, we have Dr. Mishka Turplin. He's a physician with board certification in obstetrics. How do you all say this with women?
Obstetrics
and gynecology and in addiction medicine. He currently serves as medical director of behavioral health system in Baltimore and as a staff physician at Planned Parenthood, Maryland. He also serves on the Women and Substance Use Disorders Action Group for ASAM, and currently represents ACOG as a member of the AMA's Task Force in Reduce Opiate Abuse. So we are looking forward to this very robust and informed conversation. Good afternoon, Dr. Turplin.
Good afternoon. Thank you for having me.
Great. Thank you for taking time out of your busy schedule to join us down here in the southeastern portion of Wisconsin for this very important conversation. Before we get started, I want to make a couple community announcements on a local level. This month is National Social Worker Month, March 16th. 1827, the Freedom Journal, which was the first black-owned and operating newspaper in the United States, was published in New York City. That was in 1827, March 16th. And then also, too, in 1995, Mississippi became the last state to ratify the 13th Amendment to the Constitution, which abolished slavery in the United States in 1865. Mississippi, what took so long? But we're glad they finally got around to doing it. And then we also have the Colored Child Welfare Conference on May the 17th, 2016. That's going to be at the Crown Plaza Hotel. Listen, if you don't have your tickets, if you haven't registered, you definitely want to get in contact with us over at 414-351-1100. We have some amazing workshops that we'll be presenting. This is the only conference in the state of Wisconsin that focuses solely on the needs of African-American children who are involved in the foster care system. If you want to know more information about that conference, please call 414-351-1100. And then the Partnership Council has a meeting on March the 18th. From noon until 2 o'clock p.m. And if you want more information about that, the Milwaukee Child Welfare Partnership Council, call 414-353-5500. That meeting will take place at 635 North 26th Street, right here in Milwaukee, Wisconsin. Again, if you have questions, call 414-343-5500. So we're talking about unborn child abuse and Act 292. Now, hopefully through this forum, we're going to be able to accomplish several things. One is to help the community understand what Act 292 is, discuss whether mothers should be detained if they are suspected of using illegal drugs or alcohol, and if not, why. Hopefully we'll be able to get an understanding of drug addictions and its impact on mothers as well as fetuses. We will find out whether or not fertilized eggs, embryos, and fetuses have constitutional rights, and if so, do their rights trump mother rights in the end? We would also like to know or to find out what risk, if any, are caused to fetuses as a result of drug and alcohol use. And then we really want to kind of look at those terms, drug-addicted infants, and we've heard the terms before. It's not a very, what kind of word I want to say? It's not a
savvy, appropriate.
Well, it's certainly not appropriate,
Right.
but it's not a word that we all have a tendency to embrace. There's no nice way to say it, but we've heard about crack babies and meth babies and drug babies, and so we'll look at where those terms originated out of, where they originated from, and then also, too, we'll learn a little bit about neonatal abstinence syndrome in terms of what that is, and so, and hopefully the doctors on the show today, as well as Shauna, can share with us some tips on how to care for a child who has been exposed to drugs prenatal. So how's everybody doing?
Good. Fine, thank you.
Okay, great. So I was reading, and I was Dr. Turpin. I was saying off air to Dr. Kathy Harkey and Shauna, as well as Sean, that I'm not sure exactly where I stand on this issue, because the more I was reading about prenatal drug exposure, the more confused I became about everything that I've heard, everything that I've read prior to today, and as it relates to the impact of drugs on children. And it appears that that these fetal protection laws came in existence in Wisconsin around 1997. And from what I was reading, approximately 3,000 mothers through a very small window of time were impacted by the law firsthand. So we're going to talk about what is fetal protection laws. What is that exactly?
Well, the cocaine mom law, which we don't like to use that term at all, it's really not appropriate. But Act 292 really allows the state to force expectant mothers who are thought to use alcohol or drugs to undergo involuntary treatment at an inpatient facility away from their home, and it allows a court to incarcerate the woman and or terminate her parental rights, and denies the pregnant woman her right to confidential health care by allowing medical professionals to report the woman to law enforcement or child protective services. And we've seen the devastating effects of that. I've taken care of women who have been impacted by that, and because it falls under the child protection law, these are confidential records, so it's very hard to get the actual numbers.
Okay, so when we look at these fetal protection laws, and it's not just something that's on the books or on the records here in Wisconsin, but in South Carolina particularly, I was reading something about a case where pregnant women who are addicted to some type of substance were being incarcerated despite the Supreme Court rulings that treat addiction as a disease and punishment for it as a violation of the Constitution's prohibition on cruel and unusual punishment. Despite the fact that people who are treated for drug-related health problems are supposed to have extra protection under the federal drug treatment confidentiality statute in South Carolina, by reinterpreting drug use as child abuse creates a devastating exception to the statute's privacy protection. So Dr. Turpin, can you talk about, from the addiction standpoint, why are child welfare folks and judicial folks, legislators, why are they criminalizing or penalizing mothers who are experiencing addiction?
Well, I think before I answer that question, it's important to really better conceptualize what we're talking about. Because when we talk about addiction in pregnancy, in a sense, this is an artificial construct in that nobody initiates addictive behaviors de novo in pregnancy. In other words, what we're talking about is women who might have what we call an addiction or a substance use disorder who get pregnant and stay pregnant. And the other important fact to keep in mind is that these laws actually don't distinguish drug use from addiction. And most of the women who have been caught up in them, some of them have an addiction and some of them don't. And what we know about pregnancy and drug use is that most women quit or cut back their drug use. It depends a little bit by drug. It depends, by a couple of other things. But all pregnant women are motivated to maximize their health. And all pregnant women, try to engage in healthy behaviors. And it's the women who can't change the use, who can't quit or cut back. They meet the criteria for really having a substance use disorder. So another way of looking at this is actually continued use in pregnancy is pathognomonic for addiction. So in other words, what happens is we end up criminalizing people, as you mentioned, for having an illness.
So in terms of criminalizing mothers who have an addiction, so how are people able to decipher who has an addiction and who does not have an addiction? Because with most addictions, whether we're talking about a gambling addiction, we're talking about a pornography addiction, or what you call it, a computer addiction, whatever it is, social media site, chat room addiction. We have a tendency to hide our addictions.
Right. So I think, yes. So there's criteria. There's a diagnostic and statistical manual that has criteria that have to be met in order for somebody to be diagnosed with a use disorder. And they include things like having cravings, inordinate amount of time spent, procuring and obtaining the substance use interfering with activities of daily living, school work, etc., and in particular, continued use in spite of knowledge and awareness of harms associated with it. So it's important to remember that these are all behaviors that I think are, that pregnant women with use disorder display.
Okay.
Unfortunately, some women who have not even been recently using but may still have some metabolite that they test positive for can be put into jail in Wisconsin. We've seen this happen. And so it's I totally agree that pregnancy is the time when women are highly motivated. Most of them want to cut back on anything that they know is harmful, and they're doing their best to do that. But the way the police and some healthcare workers look at this, even if they're using something that they're trying to get off of, or in some states, if they're using something prescribed, my understanding is that they have been placed in jail.
Well, you know what? I think, we all know someone who has been addicted to an illegal substance, a drug. Most of us. And even when you tell a parent and say, you need to stop using drugs for your own health, for whatever reasons, what is it about learning that you are pregnant that really can motivate folks to just say, I'm done? Because I think in some of these cases or stories that I've read, when these mothers who were taking drugs for a number of reasons, some was health-related, it could have been mental health disorders, a variety of reasons why they were taking drugs, but when they found out or suspected they were pregnant, they just discontinued. So what is it? I mean, if an addiction is an addiction, how do you stop an addiction?
Great question. Treatment.
Yeah.
So the big picture with addiction we understand is a chronic illness, lifelong, We know how to treat it. We know a little bit about how to prevent it, but we don't know how to cure it. So people who have an addiction, we want to, after the treatment, they enter into a period that's called recovery. And the symptoms can wax and wane throughout that period of time, but the importance is managing the lifelong, literally.
So tell me this, Dr. Turpin, from a trauma-informed perspective, because, most mothers and parents healthy mothers and fathers just don't intentionally harm their children, period. That's not in their nature. So from a trauma-informed perspective, what is it that you think the child welfare community, judicial community, law enforcement community, the legal community, what is it they need to know about drug addiction and prenatal drug exposure that we're not getting?
Well, I think you mentioned one of the things earlier when you stated that individuals with addictive behaviors around, let's say, computers or pornography or something, exhibit shame and guilt.
Okay.
So a lot of pregnant women who continue to use or are unable to quit or cut back who have an addiction have a lot of shame and guilt. We also know that women in general and pregnant women with addiction in particular are different from other populations of people with addictions. In particular, they're far more likely to have co-occurring psychiatric illness, especially depression or anxiety disorders. They're far more likely, and this is somewhere between 40 and 80%, to have a significant history of child sexual or physical abuse. Roughly 50%, although those numbers vary, are in a current or recent, as in past 12 months, violent relationship. They have sometimes poor nutrition and other kind of medical comorbidities. And so I think one thing to recognize or to acknowledge are the lived lives of these women that have been stressful, that can be very traumatic, and in many ways pregnancy, as you mentioned before too, is a time of self-reflection and a time of trying to maximize health and social life. And instead of, acting on that motivation from a punitive perspective, if we can capitalize on that motivation from a more healing and compassionate perspective.
Okay. So I want to kind of...
I think Shauna was going to mention something.
Oh, yeah, I was going to say that I think... Now, I have a little bit of a different story. I wasn't using... I was on a prescribed medication that is to treat opioid dependence called Suboxone.
Okay.
So I think that the mother instincts take over. For me, at least, that's what it was. I wanted to do anything and everything to ensure the health and the safety of my unborn child. And Dr. Hartke was my OBGYN, and she did a great job helping me and guiding me to do that. So that's...
So in a situation like this, because we just automatically assume that mothers who are using drugs while pregnant, that it's an illegal substance. Mm-hmm. First of all, I think we just... I thought you were going to say something, Dr. Hart.
Right. Well, I have many women who are smokers, and they want very much to quit. And many of them do, but some of them just can't do that. And that's one of the most addictive substances, nicotine, and yet they, in some cases, they just can't overcome this. And I think we have to look at this as we heard that this is a medical disorder. This is just like somebody who has diabetes or high blood pressure. We're going to treat that. We're not going to criminalize it. And what happens is just the opposite of what we want. If we have these kinds of laws, what we see happening is women don't get prenatal care. They don't come to the doctor, or they don't tell the doctor the truth. And then we can't help them have the best care for their pregnancy, which is very important.
Okay, so with these drugs that are legal drugs that folks are consuming while pregnant, is it possible that doctors, that that these individuals may be subject to child welfare involvement or incarceration or both, depending on what state they're living in. So a person who's not on cocaine or meth, but they're on some other type of prescribed drug, that they can be at risk of being incarcerated and having child welfare involvement.
I'm not sure. I would hope not, because that could have been me. I mean, very easily, it could have been me.
Because in one of the stories, and I don't want to mention the person's name, but it's pretty national. If you look up fetal protection laws in Wisconsin, there's a number of articles that reference this particular case that, like I said, went national. But I believe that mother, she had discontinued. She had went to the doctor, but she had discontinued her drug use for some type of mental health disorder, and she disclosed this while with her, I don't know if it's her gynecologist or obstetrician, and
at the obstetrician's
with the obstetrician office, and as a result, she ended up being detained for a number of days, incarcerated. So my point is that this was a drug, my understanding, that she had received a prescription for. It wasn't just some street drug, narcotic that she was on, but it was something that was being prescribed, and as a result of her disclosure, And so when we talk about health outcomes for babies and health outcomes for mothers, do you think that Wisconsin Act 292 and other fetal protection laws like this will discourage mothers from being very honest about what's going on in their life and their world?
Absolutely. And then I think it's going to make it more difficult for them to be honest and to go get the help, the proper care that they need. And then that only makes things worse for the fetus if they are not getting the proper care.
Well, I have a very good example of that. The first woman I took care of after this law was enacted was in 2005, and that's when I became interested in how we can help these women. She came to our emergency room, and she was taking some Percocet. They weren't prescribed to her. They were her mother's. She came with her husband and her 2-year-old child, and they were both working. They were married, and she was 32 weeks pregnant, and she came and asked for help. She said, I know I shouldn't be taking this medicine. And I was called. I was on ER call that day, and I called my maternal fetal medicine specialist on the way, and I said, I'm trying to figure out at this point in her pregnancy what's the best treatment for her, and he suggested that we not try to get her off of that, but simply continue that until the end of her pregnancy. By the time I got to the emergency room, the intake worker for behavioral health had called the police, and I think there are a lot of people that think they're doing the right thing, but they don't understand that it is not required to report this. In fact, in the American Congress of Obstetricians and Gynecologists documents, the recommendation is that we don't go that route. And so once the police are called, it's over. You can't uncall them. They are coming, and they are taking over, and they took her to jail, and they brought her to court in handcuffs and shackles, and she did not have an attorney. They are not required to provide one for the woman. You lose all your rights in Wisconsin when this happens. The fetus, however, did have an attorney, a guardian ad litem, and she was locked in a psychiatric unit in one of our hospitals and did not receive prenatal care for several weeks. She was put on Xanax, a sedative, which is probably worse than what she was taking already, and sleeping pills. And when I finally tracked her down to figure out what happened, she could hardly speak. She was so drugged up in the psych unit. After going to court for her, we finally, after several weeks, got her out. But during that time, she did not get prenatal care, and she was extremely stressed by this whole thing. I mean, here she was trying to do the right thing as a mom, and what happens, but she gets worse treatment. And the next time she got pregnant, she did not get any prenatal care. And other women out there understand that this is what can happen to you, and so they don't come.
Do you believe, and this question is for Dr. Turplin and for Dr. Harkin, of course, Shauna, you can chime in on this if you feel like you want to, but do you think that this law targets women who are living underneath the poverty line, who come from certain socioeconomic background, or is this something that you all are seeing in your profession that's happening across every social, whether you're rich, middle class, poor, on every class level, that you're seeing that there are women who are impacted by this, or is there a particular population of women who are impacted more?
Well, so addiction as an illness doesn't really know race or socioeconomic status. And the one thing I tell medical students is, regardless of what field of medicine you're going to go into, you're going to take care of somebody like who has an addiction. And you can't say that about any other illness except maybe cancer. That being said, the way these laws work and how we actually look for substance use and use disorder within an obstetric population augments discrimination. For example, generally speaking, I don't know about the state of Wisconsin, but in other states there's universal testing at labor and delivery, maybe or during prenatal care, but only for patients whose prenatal care is paid for through Medicaid. So people who have commercial insurance aren't being screened, aren't being tested for drugs, and therefore there would be no opportunity necessarily for this sort of punitive reporting. That's problematic in and of itself, because not asking people in the commercially insured population about drug problems, we're going to miss people where we could have intervened on and benefited their pregnancy in them, et cetera. But within the publicly insured system, yes, it's all the cases of women who have been, prosecuted, arrested, incarcerated, et cetera, tend predominantly to be poor.
Wow.
So I think part of that is from what the doctor said earlier, that many people who are poor and are on government assistance are coming from backgrounds of pain and psychiatric illness and childhood situations that are very difficult, and it's hard for them to get out of that system. And so they do, I think, when our patients go to the county mental health clinic, there's a different level of care sometimes, and I think there is some bias in that regard.
Okay. Well, we're going to take a break, and we're going to come back, and we're going to hear a little bit more about Shauna's story and what that whole experience was like, and the supporting intervention that you received from your gynecologist, Dr. Harkey, and others. There's some other advocacy groups out here that work with you and some of the other young ladies from the Wisconsin area. So we'll be right back. You're listening to Fresh Start Today.
This is Jermaine reporting from Fresh Start's WBCM studio with breaking news. Black children are flooding the local foster care system. Infant boys and girls coming straight out the womb, which means you probably have a black child in foster care, you are a black child in foster care, you're related to a black child in foster care, or you may even be a case manager or service provider for a black child in foster care. If so, then you don't want to miss the Color of Child Welfare Conference on May 17th. Fresh Start Family Services will host the only conference in the state that convenes to strictly focus on the needs of black children in foster care. This year's theme is Against All Odds, from foster care to success. There will be national and local presenters like judges, authors, educators, politicians, and journalists who were formerly in foster care, and many others. Some of the workshop titles include Black Children's Journey in Foster Care, From Total Exclusion to Over-Inclusion, Psychotropic Drug Dependency in Black Children, Black Single Mothers and the Child Welfare System. There's so much to talk about. To join the conversation, register today for the Color Child Welfare Conference and Recruitment Fair on May 17th. Call 414-351-1100. That's 351-1100. Limited seats available. This is Jermaine signing off from Fresh Start WBCM, Wisconsin Black Children Matter. Back to you.
You are listening to Fresh Start Today. I'm your host, Jermaine Reed. And along with Sean Roby, we have some great guests in the studio. And on the line, we have Dr. Mishka Turplin from Baltimore area. And then we also have Dr. Kathy Hartkey and Shauna, who are in the studio. And we're talking today about unborn child abuse, and particularly related to Wisconsin's Act 292 law, which deals with fetal protection laws here in Wisconsin. And so we have Martha. Martha's on the line. Martha, you have a question?
Yes, I do. First off, I just want to make a comment, and thank you so much for all of the programs that you provide this community with. It is just absolutely outstanding to listen to your guests talk about in detail the different causes of the various issues that have occurred to people in our community, especially around mental health and trauma-informed care. So as I was listening today, I heard one of your guests talk about the fetus rights. So I'm going to be real selfish and ask about 3 questions. Do fertilized eggs, embryos, and fetuses have constitutional rights? If so, do their rights negate the mother's right in the end? And I have another question that's kind of related. What risk are caused to the fetus as a result of drug and alcohol use? And my last question is, does incarceration jeopardize health outcomes for the mom and the infant? And we know we have a lot of women now that are incarcerated, and so I'm just really, really concerned about the impact of the mom and the fetus, especially when she's incarcerated. So thank you so much for the program. I certainly am going to hang up and will be listening. Thank you. Have a great day.
Thanks a lot, Martha.
So the first question, does the fetus have rights, and does that outweigh the mother's rights? We do not have a personhood law in Wisconsin. That was proposed about a year ago by one of the representatives, and it did not get a hearing as far as I know. It was brought to a public vote in, I believe, North Dakota, and it was voted down. So there are states that are trying to pass these types of laws where the fetus would have rights that supersede the mother. In this case, that's what happens. And when you go to court and you don't, as a functioning mature adult, don't have representation, and the fetus does, that's unconstitutional. And that's why this law is actually being challenged. And we're expecting that to be heard in court in November. We believe, and many groups are working on this, that it should be repealed and that it's unconstitutional. I've just been working with the Wisconsin chapter president of the American Society of Addiction Medicine and the American Academy of Pediatrics and the American Academy of Family Practice, as well as the Wisconsin Association of Perinatal Care. I mean, it goes on and on. The American Medical Association, all the medical groups, March of Dimes, agree that we should not be treating mothers this way, and that we need to give them confidential and accessible care that is going to be able to treat both of them. And we can't pit the mother against the fetus. They are a unit, and we have to treat the mother in order to treat the fetus. And if we don't do that, we're going to have, like you said, more people incarcerated, and it just will continue.
As it relates to the incarceration piece and the fetus development, or the fetal development, what is it about incarcerated conditions or the conditions associated with incarceration that impact a healthy development? I'm not sure if it's the diet. I'm not sure if it's the environment. And maybe some of your patients, both Dr. Turplin and Dr. Harkey, have expressed what goes on when a pregnant woman is incarcerated. What happens there?
I'll let him
Dr.
talk
Turplin.
about that.
Well,
Turplin,
I think the last example was a good example of that. What happens is actually absence of care. None of these laws actually make provision for receipt of prenatal care, receipt of healthy nutrition, social supports, etc. They're focused almost exclusively on chemical exposures as measured by urine toxicology tests. And so when people are incarcerated, they are denied prenatal care, they're denied or they have decrease in nutritional, they have less, exercise, they don't have healthy social relations, there's all sorts of damage done to work and the financial component of work. Many pregnant women also have other children, and they're unable to be the caregiver if they're incarcerated. The harms are long, and the benefits are absent.
Like I said, you asked me a while back about the comment that I made about the abuse that happens in jail. And I experienced a patient who was in our county jail, and she was brought to me early in pregnancy. She had been using heroin, and she was brought to jail for, I think, an unrelated crime. But she was acutely withdrawn. She did not get any treatment. She was denied methadone. She was denied buprenorphine. She was in chronic withdrawal. She was just a wreck, basically. And not only that, at one point they sent me a fax saying they were going to start her on, I believe it was an antidepressant, which was known to cause preterm labor. This lady had already had 2 losses at 22 and 23 weeks, and she was severely anemic. She was pregnant with twins. She needed to have good, healthy diet. She needed to have iron treatment. Right. And she was denied that because they only give medication once a day, and she was getting something else. So, just the basic things that we would do for pregnant women were denied her. Besides the stress and she was put in a medical unit where she was under a 24-hour light. She had a cot that was 6 inches from the floor, and if you can imagine having twins and being 23 weeks pregnant, trying to get up and down from there,
right?
That's pretty difficult. Another case that they're working on right now. The woman was brought to jail. She was without insurance. She had severe hypothyroidism, which was not being treated. She was fatigued. She couldn't function. She was not thinking clearly. She had a thyroid-stimulating hormone level of 100, which is off the charts, and she was not able to afford insurance, so she couldn't get her medication. When she went to the clinic to get medical care, that's when she got arrested, and she was put in jail. The whole idea was that she was pregnant, and she was also using a medication to self-medicate, an illegal medication, because she felt so terrible. She was threatened with a taser. She was asked to give another pregnancy test, and she refused because that's the reason she was there to begin with. And therefore, they put her in solitary confinement. And, these are the kinds of things that they're doing. And unfortunately, people look at women, at people who use drugs as just, morally bad. And they don't understand that addiction is a disease, a medical disease that requires treatment. And these people want very much to make a change, but they can't. And they have to have intensive treatment. And we especially are hard on pregnant women, and maybe Shauna can comment on that, because I think she experienced some of the things that most of my patients have, and that healthcare workers, especially some of the nurses, they told one of my patients it would be better if her baby died. That would be better for the child. It's just we are so judgmental and so unfair.
We're certainly not trauma-informed.
Exactly.
Exactly. Not a trauma-informed approach there. But, I have a question for Dr. Turpin, and then we're going to get into the story of Shauna. In 2004, and then again in 2013, there were some leading doctors and researchers who signed an open letter explaining that throughout almost 20 years of their research, none of them had identified a recognizable condition or syndrome or disorder that should be termed crack baby. These researchers also explained that the term crack addicted baby is scientifically inaccurate. Addiction, according to them, is a technical term that refers to compulsive behavior that continues in spite of adverse consequences. By definition, according to them, babies cannot be addicted to crack or anything else. So there's that quote. But then, and I got that from the National Advocates for Pregnant Women off their site. But then I read something from the National Institute on Drug Abuse that every 25 minutes, a baby is born suffering from opiate withdrawal. How can a baby be withdrawing for something that they're not addicted to?
That's a great question. So withdrawal is a pharmacologic and biological process by which, after the organism gets used to a substance and you remove it, and there's symptoms. This happens not just with opioids like Percocet or heroin, but it also happens with hypertension medicine. It can happen with seizure medicine. It happens with medicines which we don't associate with, which are not actually addicting. Addiction is a brain disease, but the symptoms of addiction are behaviors. So some of the substances people develop addictions to, they can also have withdrawal symptoms from. Alcohol and nicotine and opioids, for example. Other ones, people don't really have exactly a true withdrawal syndrome. Some of the amphetamines and some of the hallucinogens. And marijuana is like sort of a little bit mixed. So the withdrawal is not a defining characteristic of addiction. So newborns exposed in utero to opioids can experience what's called neonatal abstinence syndrome or opioid withdrawal, but doesn't mean that at all that they're quote unquote addicted. A newborn can't have addictive behaviors. One, and the other reason that a newborn can't be addicted is addiction's a chronic illness, and there are no chronic illnesses present at birth.
Mm.
And neonatal abstinence syndrome is treatable. Some infants don't show any signs. Others might be needing to have observation and care in the hospital for even 30 days, but long-term effects are pretty minimal.
Yeah, and it's heterogeneous. Opioid exposure is part of it, but there's lots of other pieces. Other substances, benzodiazepines, SSRIs, whether or not mom smoked. There's a genetic component, and also how we care for these infants. Infants who are breastfed or have more skin-to-skin contact are less likely to have NAS, and their course tends to be less severe. But what we would say is it's an expected and treatable outcome of in utero opioid exposure with no known long-term sequelae.
And sadly, some women are told not to breastfeed, even though that is one of the best things for those babies.
So what are some of the symptoms of NAS, signs and symptoms?
Well, they're similar to the symptoms an adult would have when an adult withdraws from opioids. So
okay.
Jittery, sweating, babies will cry more, they can have diarrhea, etc. And
poor feeding.
Yeah, poor feeding, and the treatment is at first observation, non-pharmacologic management like skin-to-skin contact, quiet rooms, low lighting, kind of the opposite usually of how we end up caring for these babies, and then if needed, medication.
What about gagging and changes in their skin color? Do you see those symptoms and those signs?
I think they can have some skin modeling where it's kind of blotchy looking. I'm not sure.
The autonomic nervous
They can have hyperactive reflexes and increased
okay.
muscle tone.
Okay. So just one of those mothers who may be experiencing or dealing with this, but you said that doctors would assess these children before leaving a hospital, then provide some care. Is it really costly to, how much more costly is it to work with infants who have NAS or who are withdrawing from drugs versus other type of deliveries?
There's been a lot of attention to neonatal abstinence syndrome in the United States over the last several years, and several big profile articles which have detailed a increase in the cost of care. So, for example, I'm going to get my numbers a little bit off, but the cost of a normal-born infant at term is about $9,000, and the cost of the care for an infant that develops and is treated for neonatal abstinence syndrome is $45,000. Now, what people should not confuse the cost of treating a condition with how significant it is for the baby. Its cost is important from the economics of healthcare, but it doesn't translate into something costing more being far worse thing to have. And in fact, a lot of that cost is an artifact or reflects how we care for these babies. For example, we care for them in neonatal intensive care units, which are probably one of the worst places to care for them because it's loud, it's noisy, bright lights, and they tend to be separated from mom. And whereas other countries care for these infants in what's called in-rooming, so the baby is in the same room as the mom, and the course of the neonatal abstinence syndrome in those contexts is less severe, not as long, requires less medication, and is far cheaper.
The American College of Obstetrics and Gynecology released a special information sheet about methamphetamine use in pregnancy, and they noted that the effects of maternal methamphetamine use cannot be separated from other factors, and that there is no syndrome or disorder that can specifically be identified for babies who were exposed in utero to methamphetamine. So what risks are presented from babies being, or infants, fetuses being exposed to various types of drugs?
Well, it's impossible really to separate out in research the exposure of one drug from another drug. And that's because lots of different reasons. But one is because women with use disorders tend not to just use one drug. A lot of them are also smoking cigarettes, and cigarettes we know are really harmful. The other thing, I think, generally speaking, in this literature and in this question, we overemphasize the risks of the chemical harms and really underemphasize the importance of the social context of pregnancy and especially the caregiving environment after birth. So we're focused on, what the methamphetamine molecule through the placenta to the fetus, et cetera, but we're not thinking about the larger social context of the pregnant woman, her social supports, her nutritional status, her undiagnosed, perhaps comorbid mental illness, et cetera. All of those other things probably influence pregnancy a whole lot more than the methamphetamine chemical.
Well, can we talk a little bit about what the National Advocates for Pregnant Women have posted on their website as it relates to fetal alcohol syndrome and the impact of alcohol exposure on the developing fetus? Why do you think that the policies and the response from, public policy responds differently, and child welfare and the legal community, that folks respond differently? I understand that, tobacco and alcohol are legal substances, but if they're causing a lot more damage, why do you think that folks are not taking the same approach or response to that community versus those who are on some of these other types of drugs?
Well, I would not advocate for treating alcohol or cigarettes the same way that we approach other substances in pregnancy.
Okay.
Through the state of Wisconsin, coerced treatment, et cetera. But we have more science on alcohol and tobacco. And alcohol does cause birth defects. We don't know. There's a lot we still don't know in terms of, is it a threshold, i.e., after you consume a certain amount that's going to happen, or is it cumulative, et cetera. But I think and we also know socioeconomically, generally speaking, but you cut up the population however you want. People use drugs at roughly the same rates. They just use slightly different drugs. So white women, especially like white upper class women, are more likely to use alcohol than any other subset of, race and SES categories.
And fetal alcohol syndrome is a lifelong problem. I mean, it's a very serious situation, and I think with any of these things, we've got to focus on education and treatment. And one of the problems that we are facing is that we don't have enough treatment facilities. We don't have enough government support for these people, and if you are poor, you can't get access to care. For women in our community, if they're going to a county mental health clinic, they might have to wait weeks to get seen and get treatment. There are, in fact, our Senator Tammy Baldwin just had a bill passed in the Senate by I think it was 97-1 for more grant money to states that would help provide treatment options, not just for pregnant women, but for substance treatment. And we were just in Washington with the American Congress of Obstetricians and Gynecologists last week, lobbying for specific improved treatment for pregnant women and getting more residential programs where they can stay with their families and not be separated from their children. These are much more effective than putting them in jail.
And I think the other thing to think about is not just to focus on what I call the pregnancy box, and to really think about reproductive health in a life course perspective. So that means increasing access for all women to family planning services and to contraception.
Absolutely.
So as to decrease unplanned pregnancies
Right.
in general. And that's probably, the best way to reduce so-called substance-exposed pregnancies.
Sounds good. We need to take a break, and we'll be coming back on the other side with Shauna's story, and then also the question, I think that's so important, not question, but the details that we certainly want to be able to share with this audience in terms of what does a healthy pregnancy look like? What are some tips that we can give to mothers who are listening to this program today that can help them have a healthy experience carrying their child? All right. Thank you for listening to Fresh Start today.
Do you know what Nelson Mandela, Andrew Jackson, Malcolm X, and Steve Jobs have in common? Each of these individuals were world leaders who were once in foster care. We often hear about the road from foster care to prison, but did you know there's another road from foster care to a world stage? Fresh Start Family Services is looking for adults to become licensed foster parents. Every child needs a caring adult in their lives. Wouldn't it be great if you could foster or adopt the next world leader? For more information on how you can become licensed with Fresh Start, please call 414-351-1100. That is 351-1100. This is Jermaine reporting from Fresh Start's WBCM studio with breaking news. Black children are flooding the local foster care system. Infant boys and girls coming straight out the womb, which means you probably have a black child in foster care, you are a black child in foster care, you're related to a black child in foster care, or you may even be a case manager or service provider for a black child in foster care. If so, then you don't want to miss the Color of Child Welfare Conference on May 17th. Fresh Start Family Services will host the only conference in the state that convenes to strictly focus on the needs of black children in foster care. This year's theme is Against All Odds, From Foster Care to Success. There will be national and local presenters like judges, authors, educators, politicians, and journalists who were formerly in foster care, and many others. Some of the workshop titles include Black Children's Journey in Foster Care, From Total Exclusion to Over-Inclusion, Psychotropic Drug Dependency in Black Children, Black Single Mothers and the Child Welfare System. There's so much to talk about. To join the conversation, register today for the Color Child Welfare Conference and Recruitment Fair on May 17th. Call 414-351-1100. That's 351-1100. Limited seats available. This is Jermaine signing off from Fresh Start WBCM, Wisconsin. Black Children Matter. Back to you.
Good afternoon. You're listening to Fresh Start. Today is 4:04 in the afternoon. Your host is Jermaine Reed and Sean Roby, and we have on the phone line Dr. Mishka Turplin from the Baltimore area, and then we have Dr. Kathy Harkey and Shauna, who's in the studio with us today. Now, Shauna, you've had some experience firsthand with this Wisconsin Act 292, which is what we've explained in the beginning, that it is a particular statute here in the state of Wisconsin that is meant to protect developing fetuses by forcing pregnant women who admit to drug use into treatment programs. And as a part of this law, child welfare officials can forcibly confine any pregnant woman if she uses illegal drugs or if she consumes alcohol to a quote-unquote severe degree. So can you talk a little bit about how did you come in contact with Wisconsin Act 292?
Well, see, okay, I didn't exactly have any issue with Act 292.
Okay.
I was already in treatment.
Okay.
I was taking Suboxone, what I mentioned earlier, buprenorphine, for about a year when I found out I was pregnant. And I thankfully have not had the experience that some of these women have had because it's horrible. I had more of a small issue at the hospital, which is what made me want to start looking into this more. It's what we were discussing earlier with the stigma of that comes with addiction and addicts. And like, you know, Dr. Hartke was saying, the judgment of automatically assuming that these are immorally bad people. Mm-hmm. So when I was in the hospital, I had my daughter in August of 2014, and I had my medication with me, and after I had her, a nurse came in when I had guests there, guests who were unaware of what I was on, and I did not want them to know. She came in and she right away started lecturing me about, you know, my narcotic medication that I have and how I could be in big trouble. And then she proceeded to ask if I wanted the guests to leave the room after already...
Opening
to me,
the door.
yes, after breaching the
confidentiality,
exactly.
Yeah, HIPAA.
So I had them leave, and then she, you know, continued to lecture and said that I was supposed to turn that in right when I got into the hospital for the pharmacy to pretty much dole out the medication to me. She said that I needed to hand it in immediately or I would be arrested. So I didn't fight it. I simply handed it over. I was more confused than anything. You know, I was vulnerable. I had just had my daughter and I was upset. I cried a lot. I guess I was confused. I'm not really sure how it's my job to know the hospital's rules or protocols. You know, I'm coming into the hospital in labor, and that's the last thing on my mind is my medication that I am legally prescribed and take every day. So I had to deal with that. Like I said, thankfully not anything close to what some of these women have had to deal with, but I get it, and it's the stigma is a problem. We need to educate, definitely.
Dr. Turpin. Are you there, Dr. Turpin?
Yes.
Question for you, because off air, the issue or topic of human trafficking came up. And there's a lot of young ladies who, while caught up in that lifestyle, and I don't know if I could say lifestyle, in that situation, in that circumstances, are subject to a lot of unwanted pregnancies, pregnancies where there is the presence of drug use and or even possibly abuse. Are you seeing on the East Coast that there are young ladies and mothers who are coming to you in your practice who are caught up in trafficking, and how do we address this piece right here where their babies, where they're not, one, being incarcerated for being criminalized for being pregnant?
Well, I can't speak to that from a great amount of clinical experience. I do know that we do a very poor job, I think, of identifying victims of sex trafficking in clinical medicine. And undoubtedly, these women pass through our care, and we haven't asked them or talked to them about it.
Okay. So, on a local level here, want to bring it back here. Just trying to figure out what is it that we need to share with mothers around a healthy pregnancy. What are some of the tips that you all can offer to individuals to help with a healthy pregnancy?
Well, first of all,
especially if there's any type of drug use, of any sort of legal, not legal drug use involved.
I think the first thing is that we would encourage all women who are thinking about getting pregnant to visit with their doctor first, because there are certain things that need to be screened for before you get pregnant that can improve the the health of the pregnancy and of the fetus. So planning pregnancy is important. I was at a Women's Health Policy Summit yesterday, and 46% of pregnancies in our state are unplanned, and we have to do a better job of that. We have to, as we said earlier, provide contraception that is accessible and not going to cost women money, and we're improving on that, but it's not there yet. But then once they come to the doctor, in addition to doing the routine kinds of questions, it's really important to do a substance abuse kind of a checklist and do that in a very non-judgmental way, that you let them know that this is something that's routine, and you ask them questions that are open-ended so that you can let them talk and not feel like they're being judged. And then there's a whole list of there's several tools that can be used to help determine whether they have a substance use or abuse situation, but also ensuring that you're going to keep it confidential, because if you don't do that, you will not get honest answers, and that's where this whole law comes in. We have to protect the patient-provider relationship, and if we don't give doctors and patients that right, then we won't be able to make this any better.
There's some mothers that's, let's just say it, they're going to use drugs, for whether it's an addiction related or folks use drugs and they're pregnant. So what is the best way to protect a baby or fetus if the mother is going to engage in drug use?
Well, actually engaged. So one, I completely agree with pregnancy. The most important visit during your pregnancy is the one that takes place before you're pregnant. The so-called preconceptional visit is the most important visit. After that, we know that women who continue to use drugs during pregnancy but are engaged in prenatal care have birth outcomes that are very similar to the general population.
Okay. And
so engagement in care seems to be is important and important to support. So just because somebody is using doesn't mean she gets driven from care.
Okay.
Because that would be harmful.
Also, if you can each time work with them, you may get a window where you can get her into treatment and make a long-term difference, because this is going to be with her for her life, and like we said, we can't cure it, but we can certainly treat it and get a remission. And if they're using illegal drugs, like I said earlier, their lifestyle is going to be one where they could be engaging in prostitution and theft and violent activities, and then they're exposed to sexually transmitted infections and harm to themselves because of the relationships that they're in. So just continuing to work with them. We just had a case I heard about where for whatever reason, I think they asked the right questions throughout the pregnancy, but the answers weren't there, and so after this woman had her baby, she was about ready to go home, and her partner came to pick her up, and they found her unresponsive after shooting up with heroin. So we can't protect every person, every baby, every situation, but just working every time that we see patients, if they are using, to try to. I mean, with my smokers, I'll ask them each time. How much on average are you smoking now? Have you cut down at all? And reward them when they are making positive steps in the right direction.
Yeah, to echo that, I think it's critical in general, but in this topical area in particular, to treat people with dignity. Right. Because some of these women really have never been treated with respect by the healthcare system, and they're justifiably wary of your questions at first, etc. But the one thing that prenatal care is it's frequent. And so what I try to talk to when I talk to obstetricians, gynecologists, is that you want to be establishing a strong therapeutic alliance, be non-judgmental, and treat somebody with dignity, and that will become a platform upon which people over time, and you have time in pregnancy, will be more forthcoming and trusting. But when the state interferes with laws like this, it makes that work hard and sometimes impossible.
We know in our country, maternal mortality is going up, unlike most developed countries where it's going down. That means more mothers are dying when they're pregnant. And much of this is related to obesity, and we fail to look at that or be able to get people to understand that our obesity epidemic is a serious problem for the fetus and the mother. And so with each visit, I talk to the moms about their nutrition and about their exercise and just general health.
Well, this has been a very interesting conversation. Dr. Turpin, thank you for taking time out of your busy schedule to be a part of this dialogue. And I think we've learned a lot about addiction and what's happening around these fetal protection laws and prenatal care. And so we really do appreciate you taking time to be on the show today. And
well, thank you so much for having me.
All right. Thank you. And so we got the situation here where there's a lot of children who come into care. When I say come into care, they come into foster care. They come into foster care, and some of them coming straight from the hospital because they were born positive. Right. And so I'm wondering, as a gynecologist and working with babies, when that child is separated from their mother, that is a traumatic experience. And so what type of tips or advice can you give to foster parents who are working with a child who has the presence of drugs in their system?
Well, I think some of the symptoms that we talked about earlier, you want to be calm and have an environment that's quiet and soothing and a lot of holding. But ideally, we want that mother to be with that baby and to breastfeed. That's going to be the best treatment. And we're hoping to get more facilities. We don't have many in Wisconsin where we have family facilities where they can stay together or with their other children. That's the best thing. We need to have family units back.
But if child welfare is intervening at the time of delivery, now that child is placed on an order, for removal and placed into care, and you're talking about breastfeeding and skin to skin, all of those important things, the smell of mom, all these factors, are kind of put on the back burner, if you will, when child welfare gets involved. So I would suppose building some type of relationship between that foster parent and that birth mom to really kind of help with helping that child, soothe that child, and to respond to the needs of that infant is going to be really critical for their development.
Right.
Okay. Well, it's been great. Thank you all for tuning in to Fresh Start today, and we'll be back on next Wednesday. Thank you, Shauna, and thank you, Dr. Harkey, and for those who called in, and Mr. Roby. We'll be back next week. Be well, be safe, be warm.